for travel. More than 2 years into the pandemic, this rapidly changing virus continues to challenge public health officials who must evaluate the data and make science-based recommendations amid a hodgepodge of state and local responses. We're once again pleased to welcome Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Disease at the National Institutes of Health, to make sense of all of it and help us see more clearly what the future holds. Dr. Fauci has been the leading public health voice during the COVID-19 pandemic and is the chief medical advisor to President Joe Biden. During his career, Dr. Fauci has led the federal response to all major disease outbreaks over the last 40 years, including HIV/AIDS, Ebola, SARS, MERS, Zika, and anthrax. He is also an architect of one of the most successful disease prevention programs in the world, the President's Emergency Plan for AIDS Relief, PEPFAR, a program that addresses the global HIV/AIDS epidemic. Begun in 2003 under President George W. Bush, PEPFAR is estimated to have saved the lives of 21 million people. Like Dr. Fauci's 3 daughters, I too grew up as a child of an infectious disease specialist and epidemiologist. I'm sure we can all swap stories about what dinner conversations were like growing up in our houses. But unlike a few of those dinner conversations growing up, I very much look forward to Dr. Fauci's insight as we continue to navigate our lives in this long pandemic. Dr. Fauci, thank you for joining us today. The floor is yours.
Thank you very much, Jen. It's really good to be with you all. I'm going to spend some minutes talking about some of the lessons that we've learned from COVID-19 in our pandemic preparedness and response, and then hopefully we'll have the opportunity to entertain questions from the group. So just to put things in perspective, we know now we're about 2.5 years into the pandemic, which was first recognized in the first days of January 2020, of cases of an unusual pneumonia that were identified now retrospectively likely in December or earlier of 2019 in the central region of China called Wuhan. If you now fast forward to where we are today and look at the global pandemic and look at cases per 100,000, and you could see that in the color code of the density throughout the world. Now we have about 508 million cases and more than 6 million deaths. The death count is likely considerably underestimated, and the number is likely more than that. So here are some of the lessons that I'll very quickly buzz through, making comments on each of them, but really just to stimulate discussion. First is the global information sharing and the collaborations, which are absolutely essential to any adequate response or preparation for a global pandemic. So here we have schematically diagrammed the kinds of things that one does, namely to share research reagents, real-world clinical data, viral isolates, genomic data, surveillance samples. Things that are occurring in Africa need to be shared, in Asia need to be shared, in the Western Hemisphere, etc. The next is, what about the clinical trial infrastructure that we have spent literally decades building predominantly in response to the HIV/AIDS pandemic and to the ever-looming threat of an influenza pandemic? We have, over the years, built a substantial network of clinical trials. And when COVID-19 came along, rather than start and reinvent the wheel, we pivoted and utilized those clinical trials networks to very rapidly test the vaccines and other prevention tools. And these are things that might be familiar to some of you, such as the HIV vaccine trials network that we set up years ago, the HIV prevention trials network, our infectious diseases clinical research consortium, our AIDS clinical trial group. We put them all together, and for the purposes of unity, we renamed them the COVID-19 Prevention Network, or COVE-PN. This group was responsible for the testing of the vaccines over a period of less than a year, which led to the demonstration of the effectiveness and the safety. Next is utilizing prior scientific advances, which enabled us to rapidly respond and develop a vaccine. I wrote about this last month, or this month, actually a year ago last month, in Science magazine, where I pointed out that people were wondering how we possibly could have gotten a vaccine that is approved by an emergency use authorization from the FDA only 11 months following the identification of the virus, when usually something like that takes several years. And as I said in this commentary, the speed and efficiency with which these highly efficacious vaccines were developed and their potential for saving, which they have literally already millions of lives, is due to an extraordinary multidisciplinary effort which involved fundamental basic preclinical and clinical research that had been underway out of the spotlight, under the radar screen, literally for decades before the unfolding of COVID-19 pandemic. And in fact, in recognition of this, Science magazine deemed the COVID-19 vaccines as the science breakthrough of the year of 2020. And in fact, in this United States, and these are the vaccines that are utilized or will be utilized in the United States. As you can see, there are 3 separate platforms: the mRNA, the adenovector, and recombinant protein. Multiple companies, predominantly Moderna, BioNTech, and J&J, but also Sanofi, Novavax, and AstraZeneca doing tests, looking very likely for an emergency use authorization in the near future. Again, moving quickly, what about the prototype and priority pathogen approach that enabled us to move so quickly and will be very important looking forward ahead to the coming years of how we prepare for pandemics in the future? So what do we mean by prototype and priority pathogens? Those are the 2 ways that you address emerging infectious diseases. So priority pathogen means you anticipate a specific pathogen that already indicates its potential for a pandemic involvement. A number of organizations, the NIH, the WHO, CEPI, and others, have actually put forth a list of these pathogens. And some of them are shown here on this slide, which was taken from the WHO R&D blueprint. But what do we mean by prototype pathogen approach? And this is a concept that was conceptualized and developed by Barney Graham at the NIAID, my institute's Vaccine Research Center. And what it means is that you take a particular category of pathogens, a family, and you build on prior experiences with that family of pathogens. And these are some of the families that are on the high priority list. The one that are obviously most familiar is the coronaviruses, which gave us SARS-1, MERS, and now SARS-CoV-2. The orthomyxoviruses, which are the different influenzas. The flaviviruses, which is West Nile and dengue and others. And what you do is that you take commonalities within a family, such as basic virology, assays, animal models, antigenic targets, vaccine platforms, correlates of immunity, as well as manufacturing strategies, and you develop it for one of those so-called prototype pathogens, and you find there are many similarities within that that allow you to jump ahead when you get a new pathogen within that family. The same exact way when SARS-CoV-2 came along, our experience in 2002 with SARS-CoV-1 and MERS in 2012 allowed us to move extremely rapidly. Next, the continued surveillance of the human-animal interface is absolutely critical. 75% of all new pathogens are zoonotic, namely pathogens that infect humans, 75% of them that are new come from an animal host. And in fact, my colleague and I, David Morens, wrote last year in Cell that the imbalance of the interactions in the animal-human interface are a major component of outbreaks, be it influenza, Ebola, coronavirus, or what have you. Namely, the human health clearly is connected to the health of animals, as we've seen in so many outbreaks. Some recent example is now mounting evidence that the SARS-CoV-2 outbreak was the result of a jumping of species from an animal to a human, similar to SARS-CoV-1, which went from a bat to a civet cat to a human, and MERS, which went from a bat to a camel to a human. That is still, although we don't know precisely what the origin is, it is very likely that that is the case, despite the fact that the lab leak hypothesis still obviously has not been disproven. Next, longstanding systemic health and social inequities that we see are driving pandemic disparities. We've seen it with virtually every disease. Again, this has been written about recently, that the most pervasive disparities are seen among our minority populations, African Americans, Latino, and where we have data, also American Indian, Alaskan Natives, and Pacific Islanders. Why is that the case? Why do we see such disparities? Well, the answer to that has been obvious for decades. The underlying discrimination and the results of longstanding racism has led to a disadvantage that minorities have been put at by limited healthcare access and use, by some of their occupations, which disproportionately put them in essential work settings, as opposed to the easy ability to work remotely the way many people are able to do. There are educational, income, and wealth gaps, housing issues where some people live in crowded conditions, and it's hard to follow prevention strategies. And finally, what about misinformation? We are seeing a heavy dose of that in the current pandemic. And here are some of the crazy examples of what we have to deal with when the common enemy unquestionably is the virus. And these are some of the things that all you know. Bill Gates and I putting microchips in the vaccines that might actually make somebody magnetic, not to mention following what they're doing. The widespread misinformation about infertility related to COVID-19 vaccines. The extraordinary destructive anti-vaccine propaganda of Robert F. Kennedy Jr. Senators who say that COVID vaccines are killing athletes on the playing field, and also a variety of other mis and disinformation. So, with those lessons learned, getting back to COVID now, what's the end game looking ahead this year and beyond? Let me explain something that has recently maybe had some misinterpretation of a description of different phases of the pandemic. So let me try and clarify it now. When you look at pandemics, there are 5 ways of looking at it in what I call different phases. Let's start off with the phase of eradication. Are we going to eradicate COVID-19? I say that's almost impossible. We've only eradicated one human viral pathogen in history, and that is smallpox. And the reason we eradicated it, there was no animal reservoir. It was phenotypically stable. Smallpox from 100 years ago is the same as smallpox 50 years ago and 40 years ago. There was a widely accepted global vaccination campaign, and importantly, the immunity that was induced by either vaccine or infection was lifelong in its durability. The next question, can we eliminate it? That means we don't eradicate it from the world, but you eliminate it from certain regions, for example, the United States. What about that? We've successfully eliminated two important viral pathogens in the United States: polio in 1979 and measles in 2000. How is that possible? Again, lack of an animal reservoir, a phenotypically stable virus. Measles from 50 years ago, 60 years ago, is the same as measles that's circulating in parts of the world now. In the United States, we had a widely accepted national vaccination campaign. And again, either vaccine or infection-induced immunity is usually lifelong or close to lifelong. So what about SARS? Why do I say it? It's unlikely we will eliminate it. One, there are established animal reservoirs, and we know there can be reinfections and reintroductions. Although we don't need it, there's enough people that are already infected. But importantly, unlike measles and smallpox and polio, we have already seen the evolution of genotypically and phenotypically diverse variants. The world has experienced 5 of them already. We in the United States have experienced 4. There is, unfortunately, a lack of wide acceptance of safe and effective vaccines with the anti-vax movement. And then, unfortunately, as we've experienced, both vaccine and infection-induced immunity wanes over a period of several months. So what are we hoping for? We're hoping for control, namely get out of the fulminant, acute pandemic phase where you have 900,000 infections a day, tens of thousands of hospitalizations, 3,000 deaths per day, and get to a level low enough so that it doesn't disrupt the society, either economically, socially, from the standpoint of what we can do in schools and in jobs. And what I mean by that, some people call it return to normalcy, or at least a new normal. Some people refer to it as endemicity. Others describe it by saying something similar to what we see with other viral infections that are present. We don't like them to be present, but they're present, but they don't disrupt society. Things like RSV, respiratory syncytial virus, common cold coronaviruses, parainfluenza, influenza. How do we stay in control? Well, you get it to a low enough level by vaccinating the overwhelming proportion of the population and boosting where necessary. But also you implement common sense, hygiene, voluntary masking, attention to good ventilation, and make available vaccines, antivirals, and monoclonal antibodies. I'll stop with this last slide, going back 14 years to something I wrote with my colleagues in the Lancet Infectious Diseases, in which I briefly described that emerging infectious diseases has been with us since the beginning of civilization, from before the time we could record it. We've seen it in recorded history with diseases like pandemic flu of 1918. We've seen it with 3 subsequent pandemics of influenza, and we're experiencing it now with COVID-19. And the bottom line is, since these infections are perpetual challenges, we absolutely must be perpetually prepared for the inevitability of another pandemic. Thank you.
Thank you so much for those opening remarks. Tons of very good information in there. On Wednesday, you told the Washington Post that the pandemic was in a transitional phase, and you talked a little bit about this in your opening remarks, from a deceleration of the numbers into hopefully a more controlled phase and endemicity, if I'm pronouncing that correctly. Tell us more about what that means, especially for those of us in unmedical schooled environments. Yeah. What do you mean by endemicity?
Yeah, well, I tried to already explain it a few minutes ago, but I'll go over it again. Yes, again, there is the very acute fulminant phase of an outbreak. And the other day when I said we are no longer in that fulminant acute phase, that does not mean that the pandemic is over. By no means is it over. We still are experiencing a global pandemic. When you talk about getting it to a level of control really is not when you have tens of thousands of hospitalizations and you have 1,000 or more, 2,000, 3,000 deaths. It's when you get those levels low enough that it really is not disrupting. You don't overwhelm the hospital. It isn't a fearful threat throughout society, but there are going to be infections in the community. I don't think we're going to completely eliminate that. And again, you could pick an arbitrary number of how many cases or hospitalizations per 100,000 that would be, but it has to be low enough that it's present but not disruptive. That's what I mean by some people calling that endemicity, some people calling that return to normality. But it is something that doesn't disrupt or influence profoundly how we interact in society.
Okay, thank you. That was very helpful. I know that a lot of people are looking out for, the magic numbers, what does that look like? And like you said, it will be, it may not necessarily be a certain threshold or number. Does the study published by the CDC in morbidity and mortality indicate the U.S. has reached the herd immunity threshold? If not, when will we get there? Is that sooner or later than you expect?
Well, I recently wrote a paper a few weeks ago how the concept of how we classically think of herd immunity is likely unattainable in COVID-19. So I think we have to realize that, because herd immunity was the examples that I gave on the slides a few minutes ago when I showed what we did with measles, what we did with polio. Namely, you had enough immunity in the population with a stable virus that doesn't change. That's classical herd immunity. It makes it very problematic to get herd immunity, which means there's enough protection in the community and enough stability of the virus that it doesn't change, and enough durability of protection that you essentially don't have any infection in the community, similar to what we see now with measles and polio. Measles and polio is all over the world. In some countries, polio less so, but measles is widespread in many other countries. Yet we don't see measles in the United States because A, people are immune to it, and B, the virus doesn't change. We're not seeing that with SARS-CoV-2. We're seeing variants that emerge every few months. We've had Alpha, Beta, Delta, Omicron, BA2, BA4, BA5. So it's very difficult to really get a strong classical herd immunity when you have immunity that wanes and a virus that, in fact, does not stay stable. And you have an anti-vax movement which prevents many of the people from getting vaccinated. So that's what I mean when I described recently, we're not going to get classical herd immunity with SARS-CoV-2.
Okay, let's talk about those variants. So why do viruses evolve? At the moment, it seems like the coronavirus is becoming more communicable but less lethal. Can you talk about why that is?
Well, generally when viruses propagate rapidly through populations, they tend to adapt themselves to spread more rapidly and not necessarily kill all the hosts. So it's not surprising that you wind up seeing viruses that might be less pathogenic. But remember, less pathogenicity can be due to two factors. One, the virus can be inherently less pathogenic, namely serious, or there's enough baseline immunity in the population that even though you're not protected from infection, you're protected from severity of disease. Now, viruses change and evolve by mutations. Mutations cause amino acid substitutions in important parts of the virus, which interfere or modify their transmissibility or their severity. That's usually due to what we call immunological pressure that's put on the virus. So when a virus infects somebody, your immune system tries hard to eliminate it. The virus that's replicating is trying to escape that attack on it by the immune system. So it tends to mutate and change. When you get enough of that, and then viruses start to recirculate, the new version of it recirculates, and that's called a variant.
Okay, thank you. You spoke a little bit about the zoonotic effect in the animal reservoir for this particular disease. So how have you seen that play out in the United States? Can you talk a little bit about infection among animals, and have we seen passing back and forth?
Yeah, well, we're dealing with it literally yesterday when the CDC announced the first case of an H5N1 chicken influenza virus that jumped species from the animal host, the chicken, which is causing a great deal of agricultural problems because it's causing the culling of large numbers of chickens, not to mention wild birds like bald eagles and other singing birds. So that is an animal virus that's jumped species. Years ago, we had a rather significant concern with H5N1, H7N9, which are influenza viruses in animals that jump species. So right here in the United States, interesting you asked that question, we had an announcement yesterday of that by the CDC.
Okay, thank you. While the initial version of the vaccines were highly effective, the immunity they produced did not last that long. You mentioned that in your opening remarks. What can we expect from future vaccines? Will they be able to extend immunity, and how will they do this? And kind of a schedule can we expect? Once a year, twice a year? You know, based on the nature of the virus, will there ever be a one and done?
Well, I hope there will be, but I'm not overly optimistic about a one and done, particularly when you have a virus that tends to change, which this virus does, and it's test assess the variants that we've seen. So right now, I would hope that we get to the point where the immunity will last long enough so that you only intermittently would need to be boosted. I don't see the necessity of every 4 months requiring a booster. I don't think that's feasible, and I don't think that's really something that we'll be dealing with. But I do anticipate that, given the fact that the immunity does wane, and that happens to be characteristic of coronaviruses, I think people don't fully appreciate that prior to the COVID outbreak and prior to SARS-CoV-1 and MERS, we've been dealing with 4 common cold coronaviruses that account for, variable between 5 and 30% of all the common colds that we experience. And we keep getting infected with the same 4 common cold coronaviruses for decades. So we know from experience with coronaviruses that the protection that follows infection is not particularly durable. And you would expect, that being the case, that the protection following vaccines are not going to be durable, which brings us to the second part of your question. We are trying very hard to develop vaccines, different platforms that give a greater degree of durability of immunity. mRNA vaccines are phenomenally good at getting a high degree of efficacy and safety. But we've experienced now that the durability of protection isn't lifelong, for sure. Well, certainly not years long in the year and a half that we've experienced it. So we've got to do better. We have very good vaccines, but we've got to get better platforms and immunogens, maybe with adjuvants, that allow us to have a greater durability of protection.
Okay. So the second booster, we're already seeing that that's already approved for those over the age of 50-something. But when are you expecting to see a release for that second booster for adults and also potentially young adults, teenagers? Where are you with that? And do you think that the second booster is something that people should consider getting at this point? Or should we be waiting for something else?
All right. Two elements to your question. The first is, what about approval or eligibility for people younger than 50? As you know, the FDA, together with the CDC, came out with a declaration of eligibility for people 50 years of age or older, particularly those who are even older than that, 65 and older, and certainly with people with underlying conditions. The FDA right now, with their VRBPAC, their advisory committee, are looking at and planning what we might have in the fall as we prepare for the cooler season of the fall and winter, which would likely lead to some sort of a surge in cases. So that's being determined right now. And we at the NIH are doing a number of studies to determine what the best boost would be, that fourth dose. Should it be a variant specific boost? Should it be a bivalent boost? We have a number of clinical studies that are ongoing now to ask that. So we likely will know over the summer when we'll be able to and what we'll be able to boost people with. If you are in that group of 50 or older now, and you have any of a number of underlying conditions, hypertension, obesity, heart disease, diabetes, we recommend that you do get that fourth dose.
Okay, great. So masks or no masks? What kind of masks? Can you give us some clear guidance on, what we should expect in terms of use of masks going forward? When is it necessary? When is it unnecessary or really not all that effective? If you had to get on a plane tomorrow, would you wear a mask?
Well, if I had to get on a plane tomorrow, I would definitely wear a mask. So even though, the court order struck down the requirement for masks on planes, I think that if you want to be protected, in a situation like that, it's a person's own individual choice for the risk that they're willing to take. And each individual is different, and they assess their risks. How old are you? Do you have an underlying condition that it would make it more likely that you would have a severe outcome if you got infected? Do you have someone in your household who, if you got infected, even though you had no symptoms, if you went home and infected them, is that someone who is vulnerable? An elderly person, a person with an underlying condition, someone who might be on chemotherapy for cancer, or someone who might have an immune defect, an autoimmune disease on corticosteroids or methotrexate or something like that. If that's the case, you should probably take into consideration seriously wearing a mask, even in indoor settings when masks are not required. If you look at the United States now and the CDC metrics, most of the country is green, which means the requirement or the strong recommendation for a mask in indoor settings is not there. As the CDC has said, that could change. And if in fact a combination of cases, hospitalization, and hospital capacity change, the CDC will modify their recommendations. But the wearing of masks right now in indoor cases, you need to take a look at what your risk is and the risk you're willing to take.
Okay. I want to jump over and ask a burning question selfishly, but I know many people want to know. I have a 2-year-old and a 3-year-old. We're all just kind of continuously scouring the news for answers on when we may see a vaccine that covers under age of 5, 6 months to 5 years. On Thursday, Moderna announced that it would seek emergency use authorization for the COVID vaccine for young children. Why has it been so difficult to deliver a vaccine that's suitable for toddlers?
Well, first of all, I think it's important for the public to understand something very clearly. The FDA cannot act on approving something on an emergency use until A, they get an application from the company for an EUA, and B, they receive all of the information necessary to make that determination, and C, they're given ample time to do the very important task of carefully examining and scrutinizing that information so that when they make a determination that an EUA should be granted, that they do so in a way that you can be sure that you're dealing with a safe and effective vaccine. So the FDA is not delaying anything. The FDA needs the information, not all of which has been presented to them yet, to make a determination. And I think there's a misinterpretation that they're holding on to data that they should be moving on. That's not the case at all.
Can you explain a little bit further, though, why it has been difficult to get, it seemed like it wasn't effective. The first vaccine that Pfizer had been studying wasn't effective, or not to the level that they were looking for. So, it is obviously up to Pfizer to make the determination whether they seek emergency use or not. But from your vantage point, what happened there, and what are some of the things that you're seeing companies now do in developing vaccines that may be more effective in finding a vaccine that works in toddlers?
Well, I think we likely will have it. The question is, what is the precise dose and the dose regimen? For Pfizer, they started off with a 2-dose vaccine for children in that cohort from 6 months to 2 years, and then 2 years to up to 5 years old. And as it turns out, a 2-dose regimen did not meet the criteria that were preset to make it be available to really be evaluated enough for the efficacy for an EUA. And so they then went to the trial on a 3-dose regimen, which is what's going on now, and the data are being collected and analyzed there. So it's really a question of getting the right dose and the right dose regimen. We continually try to improve on that with newer vaccines, including vaccines for children.
And so, with Moderna asking to seek emergency use authorization, is that a sign that based off of their trials that they are seeing efficacy with this vaccine at this point? Because I know Pfizer had put forward the request but then pulled it back. So just kind of curious, what does this really dictate here in terms of Moderna's potential success in trials that they're...
Well, when Moderna submits data to the FDA, they do so under the assumption that the data will be good enough for an EUA. I can't comment on that because I haven't seen the data and I'm not the FDA. So right now, when the FDA gets all the data that they need, they will expeditiously analyze the data and make a determination based on what they do very well, is a very careful scrutiny of the safety and efficacy of the data.
Okay, great. Thank you. I know we're all hungry for that data. When do you think we'll see a toddler vaccine? Do you think we'll see it this summer or potentially later, based on what you're hearing?
Well, you're asking the same question 5 different ways.
I know.
And I'm telling you the answer, and I'm being very consistent with one answer. And that is, when the FDA gets the data and the data are in a way where they deem it that is sufficient for an EUA, then they will make that pronouncement. And I certainly am not going to get ahead of the FDA to make any pronouncement about when they're going to do that. They will do that expeditiously, as they always do things expeditiously.
Sure. I just saw a report saying a top FDA official was saying potentially as early as June. So
well, there
we'll
you
see
go.
what happens.
Go with what the FDA says.
All right. Has the Omicron variant's infection rate affected or convoluted studies being conducted on the toddler age group because it is more infectious? So if our vaccines, we're still getting infected, how does that affect something like a trial in children if the variants now are more infectious? They're not looking at the same variants that maybe were less infectious.
Well, yeah, we've had Omicron now for a bit. So there has been sufficient information, I believe, in the Omicron era to make a determination as to the efficacy of a vaccine in the Omicron era.
Okay, great. Do you envision a time when a COVID vaccine will be among the early childhood battery of vaccines?
I think that really is too soon to make any determination on that, because we are still now in certain phases of a pandemic. And when things stabilize into a steady state, And again, as I said in answer to your previous questions, we don't know when or what level that will be. Then I think it will be easier to determine if, in fact, you want to make this one of the regular childhood vaccines. But I do not think we can make that determination now.
Okay, all right. One of the earlier realizations of the pandemic was that children who contracted the virus did not, for the most part, get as ill as adults. We know now that as many as 75% of children have already been infected with coronavirus since the pandemic began. How has thinking about children and the coronavirus evolved over time? Do we have a clear idea yet about why the virus behaves as it does in children as opposed to adults?
No, we don't have a very clear explanation of why that's the case. There are certain hypotheses that have not been proven, maybe due to so-called innate immunity that the children have that make it less likely that they get severity of disease. We don't know the answer. So if I surmise, it'll become a soundbite, and that's not good. So I won't surmise. We don't know. Try that.
Okay.
So having said that, I think we better be careful. And I don't think I know we better be careful about when we say that the virus doesn't affect children as seriously as it affects adults, to then make the conclusion that it's trivial in children. It's not. Many children have been infected, 12 million or so. We've had thousands of hospitalizations. We've had inflammatory syndrome in children, which leads in many respects to a serious outcome. We've had children die from this. We've had children hospitalized. So although it is true that children in general do not get as severe an outcome as a cohort than do elderly people, we shouldn't underplay the potential seriousness of this in children. Even though the numbers are less, we don't want to be able to then accept that children, it's okay for a child to be infected and get sick. It's not.
Okay, great, thank you. Vaccination rates among children and young adults remain low. What seems to be holding parents back from vaccinating their children? Is it misconception that once you've had COVID, you're immune from additional infection, as many kids have gotten COVID already, and or a combination of other factors that may be preventing parents from making that decision to move forward on a vaccine for their kids?
I think it's multifaceted. I don't think there's one reason. There are some parents who are inherently anti-vax. I mean, no matter what you tell them, they just don't want to get vaccinated themselves or their children. There are others who have understandable concerns about safety. And for those people, you point to the very, very strong safety record that these vaccines have. And sometimes when parents don't have all the information they need to make a decision through no fault of their own, they're a bit concerned, understandable, and sometimes confused about whether or not the risk benefit weighs in favor of the benefit. And I think when you go over all the data and you carefully analyze it in an unbiased way, hopefully parents will come to the conclusion that it certainly is to the benefit of the children to get them vaccinated.
Okay. You've decided not to go to the White House Correspondents' Dinner. I'm sorry, I will miss you there on Saturday night. You called it a personal choice, but I think it might be instructive for many of us to hear how you evaluate risk, whether it's a big dinner in a ballroom or a gathering with friends and family. What factors do you consider?
Well, again, they're personal factors, and I think one person's decision, namely my decision, not to go to an individual social function indoors, is based on a number of things that I put into my own personal evaluation of my own risk. And one of the things people need to understand, you shouldn't judge one person's decision to be applicable broadly across the board to others, because each individual person has a number of factors, some of which are obvious, like age. You can't run away from what your age is, but there may be personal risk factors that people don't really want to make public. So you shouldn't question them. You should accept a person's personal decision, which should not influence someone else's personal decision.
All right. What are some of the technologies you've seen deployed to try to prevent the spread? You know, we've seen air filtration systems, ionizers. For instance, at the White House Correspondents' Dinner, organizers were approached about using a UV lighting system that could minimize viral disbursement. What are your thoughts about these types of technologies? Anything that looks promising to you, or is this so far you're just seeing sort of maybe minimal effect from some of these things?
That's an unfair question because I really can't evaluate each and every technical thing that puts forth.
Anything particular that stands out to you that looks promising?
Well, yeah, the one thing is clear, ventilation is really important. And that's the reason why you always say when you have social events, particularly when you're dealing with a number of people congregating and gathering together, outdoors is much better from a safety standpoint than indoors. And if it is going to be indoors, to the extent possible, proper ventilation is something that's very important.
Okay. Are there any variants you're seeing emerge that are greater cause for concern, either related to infectious rate or other factors than recent variants like Omicron? Or are we getting to the point where a variant is a variant is a variant, that we're seeing a lot of things cropping up? So just your thoughts on that.
No, I wouldn't say a variant is a variant is a variant, because if you would have said that, you would have really been knocked on your back with Delta and then followed by getting knocked out again with Omicron. So we have to be careful. There are sublineages, like we're seeing sublineages of Omicron that may be 20, 25, 30% more transmissible, which means it spreads more rapidly, but doesn't necessarily give you any more severity of disease. But we've always got to be on the lookout and very, very careful and vigilant about a variant that might come along that might be different enough that it really seriously evades the protection that you get from vaccination and boosting, as well as from prior infection. So you always got to be on your guard for a variant that's different enough that it really causes a significant amount of difficulty.
Okay, I'm going to ask a few questions from the audience that are coming in. This one comes from Alexander Tin of CBS News. What does Dr. Fauci make of reports of rebound symptoms in people who finished a course of Paxlovid? Do you think more people should be eligible to receive Paxlovid?
All right, two separate questions, a little bit unrelated, but appropriate questions and good questions. There are anecdotal stories, which are what anecdotes are, of people who have taken Paxlovid in the acute phase within 3 to 5 days, have done well for a few days, and then when the drug is stopped, they appear to have a rebound, either a rebound in test positivity or a rebound usually of mild symptoms. The drug is still clearly very effective in preventing you from progressing to requiring hospitalization. The 90% efficacy seems to be holding strong. That issue of real or not rebound phenomenon is really being looked at very carefully to determine what the extent of it is, and is it a real phenomenon? Because right now, it's still at the level of anecdotal reports. And when you have anecdotal reports, the best thing to do, which is being done, is to put together a study to try and validate or not what those anecdotes are and what to do about it if they are real. That's the answer to the first question. The second question, I and a number of my colleagues, including Dr. Jha and others in our COVID team at the White House, feel that we are underutilizing Paxlovid. And we need to make sure that the American public and healthcare providers realize that it is much more accessible than people realize it is. And we're making it even more accessible. We started off by having 20,000 sites where you can get it, pharmacies and clinics. We're bringing that up to 30,000 and hope to double it to 40,000 very soon. In addition, there are about 2,200 test to treat sites, which means you go in, you get tested, and if you're positive, you immediately have access on the spot to Paxlovid. So we really are underutilizing it, and we'd like to get it used more.
Okay. This question comes from Jennifer Henderson, an enterprise and investigative writer for MedPage Today. Is there any insight you're able to share on if and when variant-specific vaccines may be available, and how significant they may be, perhaps on an annual basis going forward?
Well, that's a great question, and we are actually right now testing just that phenomenon. It's a study that we've started. The companies are doing their own studies, but the NIH study is called COVAIL, C-O-V-A-I-L. And what it's looking at is people who've received a third dose of an mRNA and giving them any of a number of fourth doses, either ancestral strain specific, either variant specific, or a combination or bivalent, namely both. So those studies are actually ongoing. We started them a few weeks ago, and hopefully in the next month or two, we'll get the immunological bridging data that will give us more insight into where we're going in the future.
Okay. Coming from Alan Kotok of Science and Enterprise, what are the prospects for a nasal spray vaccine for COVID-19 or a combination influenza COVID-19 vaccine?
Well, again, good questions. The prospects for a nasal are good. We have a number of studies on our grantees, both extramural and now intramural scientists, who are looking at nasal versions of a COVID-19, which would be specifically important to prevent initial infection as well as spread of virus. That's question number one. Question number two is there's a lot of activity looking at, as we go forward, to combine an influenza vaccination at the seasonal level together with a COVID-19 vaccination, so that a person can go into a clinic in the fall and literally get both in one visit.
Okay. Question from Lori Wiegler. An issue many Americans are having is the idea of hybrid work that only suits the employer's needs. For example, changing days of week one is forced to come into the office. How can American businesses better gauge employee risk?
Well, you know, there is sort of maybe a question in that. Yes, there's a lot of hybrid work going on, even right here at the NIH, where people are coming in a couple of days a week. I think employers should be aware of what they can do, and that's a good question, to mitigate risks in the workplace. And there are a number of ways to do that. One of them is to have proper ventilation, to have proper spacing, to perhaps even diminish the density of people by having staggered coming in, people coming in 2 or 3 days, if you are in a workplace that is amenable to virtual working, because some working places are not. But for those that are, if you stagger the schedule so that you have much less of a social distancing issue, if you have fewer people on any given day. And then obviously the other is prudent attention to things like testing, staying out of work if you have any symptoms, and if you do, to get tested, and encourage your employees to get vaccinated and boosted.
Okay. Another question from Carrie Fitzgerald. You've addressed some of this, but there's a little bit of a new angle here. Will the COVID-19 virus ever stop making so many different variants? What would it take to make it stop mutating so much? Will the vaccine makers continue to update the vaccines like they do with the flu?
Well, if necessary, the vaccine makers will, in fact, continue to update the booster shots and the primary regimen as necessary. No doubt about that. But I like the middle question you asked is, how do you get this virus to stop mutating? It's really easy conceptually and difficult practically. What do I mean by that? A virus will not mutate if it doesn't replicate. And the best way to stop mutation is to suppress the virus globally, which brings me up to something that was not discussed in this interchange we've had here. And that is, we really should and do have an obligation to really help developing nations who don't have the capabilities that we do of vaccinating their population, because anytime the virus freely circulates anywhere in the world, there is the likelihood that you're going to get a variant. And we have experience that proves that. Delta came from India, Omicron came from Southern Africa. And if you have virus that continues to replicate in any region of the world, there's always the threat of a variant that will emerge and ultimately get here in the United States. So the best way to stop it from mutating is just stop it from replicating.
Can you detail at all where you're seeing, in terms of regions where you're around the world, where you're seeing the lowest levels of vaccination? And is that likely due to access to the vaccine?
Well, yeah, I mean, unfortunately, Southern Africa still has a rather low percentage of the population that's been vaccinated, but they also have a higher percentage of the population that's already been infected. So they will have some protection due to post-infection immunity. But, you know, there are a lot of things going on in the world that are different than we see right now. China's having a really serious problem. They've locked down without necessarily adequately vaccinating their population. So now they're seeing really substantial surges in big cities. So that's going to really be a problem in China.
Okay. Final question, and we're almost out of time. Irv Chapman asks, how do you feel about summer vacation travel to Europe?
You mean for me personally?
Would you go amidst our current situation with the pandemic?
No, I think if a person is vaccinated and doubly boosted and personally takes the care of when you're on a plane, even though it's not required, if not, wear a mask, wear an N95 mask, be prudent, get tested before you go. I don't think that one should hesitate if they have a vacation planned to go ahead and enjoy that vacation.
All right, thank you. Before we conclude today's discussion, let me take a moment to thank Headliners co-team leaders Donna Lineman-Legere and Lori Russo, the Headliners team member, who organized today's newsmaker Bill Pierce, as well as Club Membership Director Kate Helster and Club Executive Director Bill McCarran. We also invite you to join us for our upcoming Headliners book event on May 12th with former Attorney General Eric Holder, Chairman of the National Democratic Redistricting Committee, and New York Times bestselling author Sam Koppelman for a discussion of their new book, Our Unfinished March, The Violent Past and Imperiled Future of the Vote. And now for the last question. I know that you're a very busy man and you are also, I'm sure, under much stress. What is your drink of choice?
My drink of choice is a very cold Lagunitas IPA beer.
Oh, that sounds lovely, and I'm sure it'll be really nice in the summertime.
Right.
Well, thank you so much, Dr. Fauci. It was great to see you.
All right, thank you.